Good morning, everyone, and thank you so much for joining us today for the CHEAR Seminar. Dr. Susan Woolford is the co-director of the CS Moth Children's Hospital National Pole of Children's Health. She is a general pediatrician and an associate professor in the Susan B. Meister Child Health Evaluation and Research Center and in the Department of Health Behavior and Health Equity at the University of Michigan, where she also serves as the associate director of the Program for Equity in Adolescent and Child Health, PEACH, and the Michigan Collaborative of Child Health Equity, MyCheck. Dr. Wolford's NIH-funded research has focused on obesity and the use of new technologies to enhance provider-patient communication, particularly with diverse populations. More recently, she has incorporated a focus on weight stigma. Dr. Woolford has led leadership roles in national initiatives with the American Academy of Pediatrics and the Children's Hospital Association to impact policy and improve the treatment of obesity. Her research findings have been reported in journals such as Obesity and the Journal of the American Medical Association, JAMA, and have been covered by a range of news outlets, including Time and National Public Radio, NPR. At the international level, Dr. Woolford has provided consultation regarding obesity interventions for regions as far afield as the Caribbean to Brunei. Today's presentation will address the impact of GLP-1 receptor agonists on weight management and will explore the role of lifestyle management in pediatrics when medications are used as an adjunct to obesity care. Dr. Woolford, thank you so much for joining us. We're so excited to have you. The floor is yours.
Thank you so much for that very kind introduction. So it's like being introduced to your family. It feels like I have no financial conflicts to disclose, but I will make one disclosure that I'm going to be talking about the AAP guidelines for the management of obesity, largely established by this Institute for Healthy Childhood Weight. And I am a member of, or was a member of the advisory board, so I am inclined to agree with them. Also, I guess this is a disclosure. I know that Cal in the past has asked me to speak about community engaged work. This is not necessarily about community engaged work, but I spend a lot of time speaking to the community. So my slides are not as sort of sober as they once were. So forgive me if they are a little bit community facing, but hopefully they'll be fine with you. So as was mentioned, I have the pleasure of practicing in Gen Peds here and wear many hats. One of my favorite hats is that of my work in developing apps to help kids and families make healthy choices. And then also a newer hat and a little bit more flair is that of being involved in the equity work with Peach and MyCheck and MyChime. And then, as was mentioned, the work with the National Poll on Children's Health. And when I think about the National Poll, it highlights, well, every so often we do a project or a survey that Sarah really does not like anymore, which is the top 10, but which I absolutely love. And our top 10 often emphasizes how important people think childhood obesity is. And you'll see here that in the past, it has been the #1 issue that parents think is a big problem for pediatrics. And it is like network news out there. This is a big deal. But in hot off the press, we haven't published the results yet for the 2025 biggest problem, but obesity is no longer #1 in the list of concerns for parents about their children. And we wonder why is that the case? Maybe we think the problem is solved.
What's #1?
Can't tell you.
Oh.
What days in July? But it is, but maybe people think we've solved the problem with these, superhero wonder drugs that I'm sure many of you have heard about, that are able to have pretty significant impacts on weight. Many of us have, some people close to me have wanted to actually try them, even though they really did not need to go on such drugs. But we certainly have a problem. So we and others have shown that the prevalence of obesity has increased. This was during the pandemic. We showed that it increased significantly and increased particularly for communities with lower income. Yes.
Can I just interrupt and just point out that you kind of go back to the previous slide. Did you know that this has the number 500 all-time among all metric scores? This particular research study, I just wanted to highlight that. Congratulate Susan, how amazing this is.
Well, thank you, Cal. I'm so excited, but I do not know the actual number. I am like all of us, we have like these really great ideas, but this is just one great idea that was able to connect with a great team at Kaiser who were able to help us pip the CDC to the post in getting those data out there. But it's really quite sad, right? Like that we had an epidemic already, and then it was getting worse, an epidemic of obesity, and it was getting worse during the pandemic. It was worse for those with low income and for minority populations, minoritized populations. And other work has looked at how this is going to worsen over time. So there's this publication in the Lancet from late last year that looks at, it estimates what the prevalence of obesity will be by 2020. And here we have it, we see years on the x-axis, the percent on the y, and this is for girls, and we see the different ages here. But essentially, for every age group, they project that the prevalence will go up significantly for excess weight. So this is kids with both overweight and obesity. And lest you think boys will have a different experience, we'll show their numbers also projected to go up quite significantly. So we know the reasons why that we have this problem with excess weight is this balance between calories in and calories out, which is so much more complex than that and is affected by this whole socio-ecological model of factors. And we can't go through all of them today, but we certainly live in an obesogenic environment. And one of the things that I've been thinking about a lot recently are the ultra-processed foods that we can't avoid, but that these medications help us try to avoid. But it's not just the food. I mean, it's like everything that you can turn to. So for example, if you're exposed to pollution while you're pregnant, your children are more likely to end up with excess weight. So you just can't avoid it. There's so many factors that will lead to excess weight. And so the American Academy of Pediatrics in January 2023 came out with guidelines to help primary care providers address this issue, because we're on the front line of efforts to be able to try to help kids. And these guidelines were focused on children 2 to 18 years of age. And when they came out to some rather mixed and actually quite shocked responses from the media. You see here that the guidelines were terrifying to some, and there was quite a lot of backlash. People thought it was appalling that the AAP should make the recommendations that they made. And we'll get to what those recommendations were. In general, they emphasize the fact that obesity is common, right? So we said how it's going up a lot with over 14 million children in the US who have obesity. And it's complex, which is why it's sort of very hard to treat, and it's chronic. And I think this is an important point that we don't focus on enough, that it really has an undulating course that's characterized by responses to treatment, but then relapses once treatment ends. And that's what we've seen in the treatment that we have to date. And the fact that probably we won't see anything different with the medications, but they're being held to a standard of, oh my, they're not going to result in effects that last even when they finish. But nor does lifestyle treatment, because that has been one that people respond to when they're in treatment, but then regain the weight afterwards in many cases. So the tools that we've had to address excess weight in pediatrics have been fairly limited. I like to think of one of our tools, such as surgery. I love to think of it as a saw. We've had surgery. That is one thing that we've been able to do for to address excess weight. We've also been able to chisel away at it with our lifestyle interventions. And the AAP tells us how to. So to assess for it, look for comorbidities, treat lipids, treat our comorbidities at the same time. We look at diabetes, we look for liver problems and hypertension. And then we want to treat this really holistic way using motivational interviewing. And then we get to the issue of this intensive health behavior lifestyle therapy that they recommend. And they say that kids who are 6 years of age and older should be offered this type of treatment. And if children are 2 to 5 years old with obesity, you should consider offering it to them. Well, this was just music to my ears because this is what I've done for many, many years. And the fact that they are recommending lifestyle treatment was what I thought they should do. So I was glad about that. And I just put this here to say I'm really a card-carrying member who was drunk the Kool-Aid for lifestyle therapy, right? Went ahead and got certification in lifestyle medicine because I think it's so important for obesity and actually for a number of other factors as well. So what is it? They're suggesting that we should treat the patient, the family, using a multidisciplinary team, that we do it right at diagnosis. We don't wait and try like sort of a little bit here or a little bit there. We go as intensive as we possibly can right off the bat. We should do it in the medical home with connections to the community, and we should provide health education, help people build skills, behavior modification, and counseling. It should be done in a group setting or within the individual or both, and face-to-face, which can be delivered in person or virtually. So all of this care should be delivered by at least 26 hours of contact with the patient over 3 to 12 months. Remember, this is being said to primary care pediatricians who have to deal with 5 gazillion million other things when a child comes in, and this is just put on top of it. It really becomes quite a bit too much by the end, right? It's just a lot. And so let's think about what it is that this has achieved in the past. So in the past, and we'll take you just a little bit back, we've had such comprehensive programs. We had the Empower program here. You have all the multidisciplinary team. We do all the kinds of things that I just described, and you can have decent results. So our results showed that kids who were in the program were able to reduce their BMI on average by about 3 BMI points. And Kent Resnickow has a study that similarly shows that you can reduce kids' BMI over time in such programs with intensive interventions. But they have lots of problems, right? So attrition rates are high. It's difficult to get people in. They have low reach. You have to live pretty close by to be able to attend. People don't adhere to the recommendations, shock of all shocks. You tell people to exercise every day. They don't always do it. Then they have, once you finish the program, as I mentioned, it's hard for people to maintain those changes. The costs are quite high, and reimbursement for this kind of care is not really that great. So this is a study out of the Power Registry, which was a registry of about 33 different programs around the country who engaged in this kind of care. And so they showed that the retention rate in such programs was 15 to 74%. So for some programs, only 15% of kids stayed through the duration of the program. The median being 41%, which is not really that wonderful. And the results, they looked at the change in percent of the 95th percentile over time and over the 6 months. And you see again a range, but with a median decrease of about 1.7% over the 95th percentile. So it works, but we often like to describe it as modest. And so
optimistically described as modest. I see.
So we have hope though, because of their step number 12, their key action step 12, which they recommend that for children 12 years of age or older with obesity, weight loss pharmacotherapy should be offered as an adjunct. So now we have a bit of a power tool, right? And it's not just one medication. There are a number of different ones that one can try. How do you get somebody, however, to use this, primary care providers to use these and prescribe these? And I think there are a number of factors that come into play, but these are four that I'm going to speak about. Whether the evidence is there, do they have the education about it, have they got the experience and the self-efficacy to do it, and what they expect about the outcomes. So if we start off with the evidence, in the past, we had orlistat as a potential as the medication we could use, which slowed the absorption of fat from the GI tract. But by so doing, it caused flatulence, greasy stool, fecal incontinence, and deficits of these fat-soluble vitamins. So very few people were signing up for that. However, things have gotten better. And now we have phentermine and Topamax together. And here, if we look at the reduction in the studies, how many kids reduced their BMI by 5% or more over the 56 weeks of that they were followed. And if you use them top dose, that 47% of the study population who achieved that mark. For the mid dose, 39% of the population, and for those with placebo, it's 5%. So, pretty encouraging. And then if we look at the GLP-1 agonist that we're so interested in liraglutide, we see for a similar study, the scale study, 43% achieved 5% of the decrease in their BMI, compared to 18% with placebo. Again, pretty good. If we look at semaglutide, which is the one that we speak about the most, the Wegovy, Ozempic. Here we see that the study group reduced their body weight by 5%. The percentage who did that was 73% compared to 18% with placebo. Pretty convincing evidence that it works. And how does it work? So as many of you may know, once we eat, the GI tract puts out this GLP-1, but it causes us to feel full, and so we can then know it's time to stop eating. But it's rapidly destroyed by an enzyme in the body, and so it doesn't stay around for very long. But with these medications, they've been able to adapt this, and in the medication now, it's modified to avoid destruction, and it lasts for much longer, which is why you can get these shots. You can take them, for once a week, and it can have the impact over that length of time. It has a number of impacts, actually. It affects our pancreas as well by increasing the production of insulin and the proliferation of the beta cells that produce insulin. And so that is helpful in this process as well. It also has a central effect on the brain, so it affects our hypothalamus at the arcuate nucleus. We have there some neurons, so we have the POMC neuron. This is a great one because when it's stimulated, it makes you feel full. So that's my rah-rah for the pom-poms there. And then these medications stimulate these neurons, and so thereby they make you feel full and help one to stop eating. And then we have the neuropeptide Y and agouti-related proteins. These, on the other hand, when stimulated, increase appetite and decrease metabolism. So I hate them. So it's pretty much, why do we have to have these? But the good news is that the medication inhibits these, and so therefore it reduces hunger and reduces food cravings, right? So it's like good all the way around. Well, almost all the way around. So one of the main things that it does is that it decreases the rate at which food passes through the gut. And so then we can feel fuller longer because it's helping to keep that gut stretched. But that slowing of the gut can lead to nausea, and there can be like this paralysis of the gut too, which is very rare. It doesn't happen often, but it can happen. The nausea happens most frequently, and seemingly maybe even more in kids than in adults. So
how often does that happen?
Can't remember the numbers offhand, but I do know that it is one of the main reasons why kids will stop taking medication. medication.
On those who stop.
For those who stop. And so also, the GLP-1 agonist will have an effect on the thyroid, and there it has an effect on C cell proliferation. And so then there's this increased risk of thyroid cancer. Again, very small, but one has to remember that it's there. So when we want to start these medications, we do an e-consult to Joyce and the endocrinologist, who have reminded us each time when we're about to start it that we want to make sure that people don't have a family history that would make them at greater risk for that. However, when we weigh this and we look at weight loss, the improved comorbidities that we can see with these medications versus the side effects, long-term impact, in that we believe that once you stop the medications, you will likely regain the weight. At least all the studies seem to suggest that. And of course, the cost is very high, over $1,000 a month in many cases. So if you don't have insurance, that's pretty tricky. But even if insurance is paying for it, that's the kind of thing that can bankrupt any sort of health system. If everybody who could get it were to get it.
What's the cost relative to the intensive weight management program?
Right, so that's a really great question. So when we look at the cost for this, as we're saying, it's about, somebody did an estimate, they were saying about $1,000 to $1,600 a month for the medications. And so if you multiply that by the 40-something% of adults who have excess weight, they haven't done it for kids, but it's about the 40-something% of adults who have excess weight, and them taking it like throughout the whole year, they estimated something like $4.2 trillion being spent, or 4-point-something trillion dollars, and we already spend like 4-point-something trillion dollars on healthcare in general. For the intensive programs that we have, those programs tend to cost something more like $2,000 over the course of 6 months. So it's not really
So it's cheaper in the short term.
the intervention. No, this is $1,000 a month. I'm saying $2,000
a year.
over 6 months or so.
So it's more expensive.
So it's more expensive than the interventions, but
It works.
it works. And what makes a drug cost a certain amount after you've developed it, right? And will it always stay at that cost? So, I mean, those are things that I think will shift over time. So when you weigh it out, it still seems that the pros maybe outweigh the cons as far as the evidence for using it. But then, do pediatricians even know about using it? So with one of our summer interns, we looked at review of the literature, looking at what physicians know about this, or pediatricians know about these guidelines, and found that in a study published in 2024, which is about a year after the guidelines came out that recommend the use of these medications, 24% of pediatricians, primary care pediatricians in the survey, were unaware of it. 36 of them had read the guidelines, but were aware of them, but had not read them. 27% of them reviewed them, but were not familiar with the specific recommendations, and only about 12% read and understood it. So, which is not surprising. I mean, people have a lot to do. They're not sitting around waiting for the aid. People talk about obesity like I am, right? So it's not entirely surprising that they weren't terribly aware of it. And when we think about the experience with it and the willingness to prescribe it, the same study suggests that 34% were willing to prescribe, 42% were uncertain about it, and only 24% were willing to prescribe it. And almost 2/3 agreed that AOMs, these anti-obesity medications, should be managed by specialist physicians only. Well, most kids with excess weight don't make it to endo to get medications there. So this would mean that there would be a problem with access if you could only get it from your specialists. And it's sort of interesting that that's what people think, while in the adult world, people are buying it online with like the least bit of contact with a provider.
So, but this survey must have been done already 2 years ago, because even though it was published in 24.
It was done towards the end, like the data collection was towards the end of 2023, so they had been out for
So
months.
time, right, like over time, this will change also, probably.
Yes, I believe it will change. And the question is, are these medications going to be like medications for hypertension, where we send everybody to Zubin to start it, and then we, manage it thereafter? Or is it going to be more like ADHD, where every pediatrician feels really comfortable doing it?
But we didn't
Don't know.
always.
We didn't always, right? So and I think it may lean more towards the ADHD side versus the hypertension side from a standpoint of the prevalence of the condition, right?
Yeah.
I mean, with hypertension, we don't have as many kids, so we can never get as comfortable. Whereas with obesity, there's so many more kids.
shortage.
It's not a shortage. So there may be a shortage we want to be on it, but still, it won't be a shortage. There'll still be enough. So let's look at their confidence in prescribing these AOMs. So we here at U of M decided to do a survey of our primary care providers to ask them about their experience with prescribing these medications. And I'm going to present a few of the results here to you. We got about 38 of our primary care pediatricians to respond. And of those, just over 35% were not confident at all with prescribing these medications.
When was this done?
This was done a month ago.
Okay.
Interesting.
And just before PAS, so time flies, so about a month since it's done. And a similar percentage was slightly confident. And we had just over 25% who were moderately confident. And I can keep clicking, but nobody was very confident yet with prescribing the medications. And I think we find it very different. We didn't field it to family medicine. We were sort of deciding whether to or not. But we think that with family medicine, they're going to be much more confident in doing it because they're doing it with adults. And even though they still want to partner with peds to do it with pediatrics, they're still going to have a little bit more confidence about it because they're used to doing it.
So this reminds me of some studies that were done at CHEAR by Jerry Rushton a while ago, when antidepressants like the SSRIs first came out.
Ooh.
And did people feel comfortable prescribing Zoloft and all those kind of things to kids? And how you're right, the family physicians, because they've been given it to grownups, they were like, no big deal. They just like cranked it out. And then there was this like 5-year process of pediatricians who like never prescribed that was always a psychiatry thing. Over time, became more and more confident in their ability to do it.
And this is likely the way it will go. We may also get more evidence in kids. And I haven't included it here, but I showed you the studies. Those were studies in adolescents that showed all the benefits that I spoke about for 12 and above. But there have been recent studies for younger kids. So with the GLP-1 agonists and receptor agonists in 6 to 12-year-olds, and it was similarly positive. They also, I think, had more of the nausea than as you get older, but it proved to work very well. So now that we are to a large extent, beyond the shortages around the medication, that was one of the big problems initially. Now the problem is not so much a shortage, but the expense and getting insurers to cover it. And so as those things are ironed out, we can imagine that more kids will be on it, and even younger kids.
So one quick question.
Mhm.
What is confidence in this instance? Like if you're comfortable doing something, but you have no confidence in your knowledge of what the drugs actually do, so
The confidence, we asked them, how confident are you in prescribing these AOMs? So it's I think, like, as Gary was pointing out, when we first were prescribing like Zoloft, we weren't confident, we weren't, because we didn't know as much about the side effects, we weren't as familiar, because when you're familiar with a drug, you can prescribe amoxicillin in your sleep and you know what the side effects are gonna be, and you have no worries about, weird and wonderful things. When you don't know something as well, then I think it's a function of their experience with it. And they will become more confident, and I think it would be.
So confidence in their ability to prescribe.
Mm. So that is one factor we asked them about. We also asked them about their concerns for prescribing AOMs. And so you can see here a list of the concerns that these were the lists that were provided to them, and they had to endorse as many as they felt were concerning to them. And we see here that the ones that were more than 50% of the respondents indicated that these were concerned, but the difficulty with insurance coverage, that by far and wide is the biggest concern. And the need for long-term use in order for these to work. But again, I pointed out earlier that lifestyle doesn't work after you stop either. So, and some amongst us wonder whether it works at all, but it does work. It just requires that you keep in contact with patients. And so this is going to be the same. But here, the worry is that, of course, if you have to give a kid a medication for many, many years, are there going to be effects that we don't know about? And so one of the things that people are concerned about here is what it will do to growth and development. So if you're not eating very much, your calorie intake is limited, what is it doing to like your bones? Are those not going to develop in the same way? And these are questions that we don't know, and by the time we know, well, some kids will have been on it for a long time. So I don't think the worries are unfounded. And so over 70% were concerned about this need for long-term use. The side effects and adverse reactions were concerned, the high costs are concerned, and the absence of the long-term data. And then the effect on the psychosocial effects and the possible stigma attached to it. So one wonders about that, because there's certainly this idea that if you take medication, you've taken the easy way out, and that's some sort of stigma attached to that. There's also a huge amount of stigma, no pun intended, on being a kid with excess weight, right? There's like a lot of stigma there as well. And we in the healthcare system contribute to that in many ways too. So wherever a kid goes, whether they're in school, whether they're out in society or in the healthcare system, they have to deal with that. So the medication may come with some stigma, but it may also remove some as well.
Susan, you have a sense of how, or maybe one idea might be to like repeat this among pediatric endocrinologists, because I imagine that actually many of the concerns are the same. Some of them may be different in terms of things like lack of, the endos probably feel a little bit more comfortable generally because they're prescribing it, but I can't imagine that these are not the same concerns for that. And it may not be the case, obviously, like maybe the discomfort with dosing is not there, so there may be some differences, but I just think that would be an interesting comparison.
Absolutely.
I would piggyback a little bit off of Kyle's point. Is I think at least something what I'm gathering from what you're saying is, it's a lot about kind of your uncertainty and your kind of willingness to accept the unknown part of the kind of medication prescribing. And I think maybe one of the reasons that a lot of these issues sometimes get deferred to some specialists, being one of those people that gets all the blood pressure referrals, and I end up handling most of the blood pressure long term too. But I do agree that the family medicine docs will just like start them and then send them over. Is that it's just kind of a degree of tolerance. Like I just don't have the option to wait for medications that become approved or have a lot of data behind them, because my patients don't have the time to do that. And so I'm using 95% of what I do, 99% of what I do is completely off label.
Wow.
And so, I think there's a comfort level that comes with just being in that space chronically. That I think some of those, there may be a little bit of a difference between, I think you'll probably see the same degree or same kind of breakdown of these things. But when it comes to just like the comfort level of, you know, diving in, I think that was probably gonna be different.
I also think that whether or not over time the concerns go away or don't go away, whether or not they prevent someone from prescribing, right? Like you can still have the concern, but you're just plowing through anyway. Like I'm sure Zubin, you have some concerns about some of these drugs, but you know what? I'm gonna do it. And I would say the reason why this might be relevant is with regard to prescribing practices. Because if these, I mean, yes, all these are important issues. I don't think anyone would say, no, these are not important issues. But whether or not it's really kind of makes a difference besides just being interesting is whether or not it affects prescribing. And if any of these go down and then people prescribe more, or they stay and people prescribe more, I think is really, to me, the fundamental issue.
And I think some of it is standard of care, right? So if all your colleagues are doing something, or you have the sense that people are doing it, then you're more willing to go along, even if you're not convinced of certain things.
I think that's so true.
It's the standard of care. And I don't think we've quite reached there yet with these medications for peds, but I think we will.
Because some of our, like, I don't know, like you said, 38, build this out. I don't know which clinics they practice at, because some of our clinics are probably doing this more than others. You know what I mean? Like I know at Canton now there's 3 people who are prescribing this medicine, which I find fascinating, you know, and that, but once the first one started, like you said, it's gonna be the standard.
I mean, I'm considering doing it for some of my hypertension patients, right? I mean, hypertension and obesity obviously are kind of going together in a lot of ways. But
Don't put hypertension as your primary diagnosis, though.
don't.
I've made that mistake with type 2 diabetes.
That is correct. That is correct.
Yeah, I mean, I will say that like, the reason why we're able to successfully prescribe is because we have farm techs who like deal like with the like 12,000 acrobatic moves to like figure out what to sort of bill for first, then get rejected, then go to children's special health care, or like this payer does this and that payer does that, and then you have to do all this like attesting to like weight loss, or then I had to be like, oh, like he would have like gained more weight, so you know, like the net difference is still better even though his weight is stable, right? Like that's just the biggest structural problem, because you guys don't have that support in primary care.
We absolutely don't.
And so then that just by definition, yeah, and then we're still like, we're opening up a little bit, but we have like no capacity, right? So we have our obesity letter, which says we do not see children with obesity unless they have these like very index hormone conditions, right? So it's a huge issue. And so then, I don't know if you guys have heard of like Known Well or Mochi. So there's actually like 2 telemedicine companies that are directed at kids. So it's like the adult, like the counterpart to the adult telemedicine program. But like, and so, you know, you might say like, oh, well, like they're gonna prescribe all these medications and it's gonna be like overuse, right? But honestly, they're just responding to consumer demand for something that like you can't get in the regular delivery system, right? Like we reject like 50 to 100 referrals for obesity a month is what the call center tells us.
Oh my gosh.
There's a capacity issue, right?
Yeah, because if we did, like, we'd have no ability to see like any of our patients with diabetes or anything else, right?
I need that stat is gonna be very important, which we'll get to it in a second.
But that's nothing new,
That
right?
isn't-
Yeah, that's
People
not
have been rejecting it forever.
Yeah.
Susan, you might get to this, but I wonder when I read through these concerns, I wonder when you talk to patients or families, how these flip, right? Like thinking about some of the things from lack of long-term data on bone growth down, like those are the types of things that I hear in the parent community around hesitancy or concern or worry about these medications. And so it's just interesting to me to think about the prescribing comfort, and then you all of a sudden you get your providers more comfortable in prescribing, and then what are the barriers with families actually wanting to receive that treatment, right? And then you're in that space. So I don't know if you get to that or not, but.
That isn't part of today's presentation, but it's a key point of what, and one of our other presentations, we talk about the physician level factors and the patient level factors that might be impacting this. I think it was in our poster actually in Hawaii. But those patient level factors, I don't think we've explored extensively. Some of them are things that, and if you're discussing the ones lower on the list, for example, developing eating disorders, right? It's something that people often think about when they're discussing weight management interventions, and they worry about the fact that they will cause these. The AAP guidelines really highlight the fact that that hasn't been the case, that when you keep kids, and that's one of the major reasons for suggesting that these medications are to be prescribed in conjunction with an intervention, because when kids are in these interventions, they very rarely develop an eating disorder. In the years, almost 10 years that we had a tertiary care program here, I can think of 2 kids that seem to have developed an eating disorder while in the program. And our experience is similar to others. Whereas kids who are not in a program are far more likely to develop an eating disorder. And so, yeah, so what will be concerning to parents is something that we have a lot of studies lined up. We're looking at endocrinologists, we're looking at parents.
I had an additional point to that, is that at least in our experience, when we talk to families in kind of the nephrology space, is actually, it's the flip. It's that they're not as concerned,
Right.
as families are, as providers are, as clinicians are about all of these concerns. They are more concerned about getting the care that they need to get for their child.
They're thrilled with the idea that something could actually work.
Correct.
Right.
Oh, I was just gonna say something similar to Joyce, which is I'm thinking more about the adult primary care, like introduction of GLP-1s. I mean, I've even in residency was prescribing them for my adult patients. And part of it was because of the development of local pathways to facilitate that for providers. So like pharmacy worksheets that help you with dosing ramp up, and pharmacy techs who help with prior auths, and developing a pharmacist consult system that helps with like managing side effects. So I think all of that is like the team-based care, primary care model that I just think it would be too hard otherwise, so.
I agree, absolutely. We need that infrastructure to help us. So finally, as we relate to this survey, we asked PCPs about the resources that they needed. And I was really happy to see that the vast majority wanted referral opportunities for intensive health behavior and lifestyle treatment. And we're going to talk next about what we'd like to provide in that space. So they want help, because just doing this in primary care is really hard. I mean, prescribing the medication is one thing, but if you're supposed to also provide this intensive intervention, like that is not possible for most people to do in a primary care setting. So that could make you pretty distressed in the end, but there is hope. And before I get to the hope, the more distressing actually is the fact that these with the medications, they could possibly add to disparities. And so we know that Asian, Black, and Hispanic youth have increased odds of being diagnosed with obesity and being screened for comorbidities. So they're being screened for the comorbidities, which is good. They're being diagnosed, which is good. And you're more likely to get treatment if you are, your excess weight is documented. But I want to drop to the final point here that Black and Native American patients had lower odds of being prescribed AOMs. So with that in mind, there are those who have looked at how these disparities in prescribing the AOMs may lead to worsening of the disparity as relates to weight for kids of different races. It's interesting though, in our setting with Peach, we started looking at prescribing, how were the medications for obesity are prescribed differentially by race. And we haven't found a difference here at U of M we haven't found that Black kids are being prescribed medications at a lower rate than whites. But we haven't finished that analysis, so that's again, wait for the response, for the actual results of that one. So this, worsening of the disparities could be quite concerning. But now that we are aware of what can be done with the medications and some of the pros and cons of them, and just highlighting again that they are to be done in association with behavioral interventions, we need a tool that brings it all together, both the medication and the lifestyle, and we need to construct that. And so putting on our construction hat, we are creating the Michigan Intensive Pediatric Lifestyle and Navigation virtual program. And it brings together like the curriculum, much of the curriculum that was developed through Empower years ago, the Adult Weight Navigation Clinic, which is all virtual, which is a space that I very much want to move into, because the idea that people have to come for 26 contact hours in person into a clinic is a huge burden for families. And when you have to bring one child, you have to find childcare for the other children or drag them along, it's like too much. So I think this weight navigation approach of having it be virtual is a fabulous way of doing it. It wasn't possible before the pandemic because of all the rules around the portal, but then once the pandemic started, all those rules went away. So now we can do it. We want to bring in some of the technology like the apps that we have created, and use the possibility of remote monitoring to be able to capture the data that we need. And so to create this, and working with Mohammed and Dr. Nassif, and we have a project manager, Jocelyn, and this is being supported by the Caswell Diabetes Institute to get the pilot off the ground. We have created our website where we have put all of the content so that they can, patients can go in and get the content and use it at their leisure. I will say that we've created a like initial pilot site, but it needs to be made into a U of M site, which is, as we all know, not an easy step. So one day that will get there. And we have an app, not the app actually that we created for our last NIH project, because that was one that used location and had lots and lots of problems. That was a different presentation in which we talked about the many things that could go wrong when you're trying to look at location. So, but we took the content from that and partnered with a group from Michigan State who have this app that you can, many researchers can use. And so patients can enter their weight there and other data that they may want to share with us. And we can send them tailored messaging. We can send them daily encouraging messaging through the app. So kids can sign up for that. And importantly, we'd have this new network that brings together the medical surgical providers. We'd have exercise, nutrition, behavioral, and pharmacy all involved. And we've started trying to build out that network already to be able to help us not just provide what a primary care provider could do within our setting, but be able to bring in this multidisciplinary approach, working as this network that includes people who can help with the medications, as has been said. We need pharmacy involved if we're going to be able to navigate that part, so that providers in primary care won't have to necessarily do it, but somebody in each clinic would be part of this network, who would be, or somebody or more than one person would be part of this network, and make it easier for the kids in that clinic to be able to get access to the medication, but not just the medication, but also the lifestyle. And while in the beginning, we're thinking about, is the problem solved by the superhero medications that have come along, I would like to suggest that it really is the network team of providers who would be the superheroes who can provide the care. And with that, I'd like to say thank you. And this gives me joy to think of the possibilities. And I'm happy to take questions. Any questions at all?
There's a question in the chat from. I can read it. There are two
Yes, please.
questions. So how long do insurance companies continue to cover the cost for an individual patient? Is it open-ended or limited to a set time? And estimates of cost of monthly supply to produce GLP-1s range from 75 cents to $72.49. In terms of policy, when should we expect prices to decline because of competition? And if not, is pharma guilty of price fixing?
Okay, so we're being recorded, so I guess I'm not gonna say there's like price fixing. So I think you raise a really good point, and I think this is the issue. We're saying that cost is a barrier, but cost is flexible. And so if there's advocacy in this space, if there's competition in the space, I mean, these are factors that ultimately will, I believe, impact the cost of these medications. There are those in this room, I think, who know more about the cost of medication, but any thoughts about cost of medication or how this might change over time?
In theory, competition should kind of bring costs down over time. But it's probably more when they go off patent,
Yeah.
right? Which is 7 years from the time of approval.
And they-
So, where it depends, of course. They can always extend. There's also ways for them to manipulate such a system so that
They change,
Including a pediatric labeling.
The indication, they change the labeling.
Somebody will introduce an authorized generic, which is half the price. So it's $500, right? Instead of 1,000, which is still a lot, right? Given the amount of use, right? And what that does, of course, that it decreases the out-of-pocket costs, and so that reduces demand for patients. And then you end up with more utilization and the same net spending or more, right? So it's a really difficult problem in the absence of just price negotiation, frankly. But these are, on the other side, these are blockbuster drugs. This is what this is what we want the pharmaceutical industry to be developing, right? They should be generating a financial windfall from this. The question is how do you balance that with access, spending, and not essentially raising the federal deficit by, essentially having Medicare and Medicaid cover these drugs.
And it's the balance is not just against the cost of the lifestyle interventions, but excess weight causes so many problems and costs us money outside of healthcare costs, right?
Yeah.
Like we don't have enough people to go in the armed forces because of excess weight. I mean, it has other costs as well. And so I think that somebody who does these kinds of assessments would have to balance all that out.
Those ROI,
That's actually a really, fascinating thought in terms of potential funding for your work. Would be DoD.
Yeah.
they come out with basically a list of things that they'll fund every year.
Yeah.
In February. And
That's
so,
definitely worth keeping an eye on. And we have some contacts at the Pentagon still from when the woman who was the Assistant Secretary for Defense, who was our Meister lecturer about a decade ago. I think that there may be some opportunity. I'm happy to talk to you about that.
That'd be great.
The challenge here is that there's probably little doubt that these drugs, as with many pediatric inventions, may be cost effective over the lifetime, right? Because I actually don't know that for a fact, but that's my sense, right? It may be sensitive to some of the inputs, obviously, but I think there's a very good chance. The problem is that the people who benefit from that are not usually interested in lifetime horizons, right? So DoD may, because they kind of capture that population for long term, right? Medicaid, maybe, right? Should be, but of course, not everybody stays in Medicaid, and of course, so maybe there's some incentive there, but the commercial insurers do not, right? Because you churn on and off and your commercial insurance every 2 or 3 years, right? So they don't care, right? They're only looking at short term. Not that they don't care, they are really mostly considering the short term.
I will say though, when we first started the weight management program back in 2007 or something, we went to insurers. I remember distinctly sitting at a table much like this with insurers and being told that these things don't work, go away and show that it works. And they were not willing to really reimburse in any significant way. And so then we did go away and show that it could make a difference. I know we're all laughing about the modesty, but it worked to some extent. And then they did start paying more. In fact, they came to us and funded a project to try a particular program for them. And so their willingness to pay changed over time. And so maybe the same thing would be true for the medications. I mean, the results are so much more dramatic. And so maybe over time they'll be like, okay, we're more willing to pay for this and pay for it for a longer period of time.
Someone has their hand up.
Oh, Erica.
Yeah, so I was the one who put the questions in chat about cost, and I'm not suggesting that use of these medications is the solution to a problem. The solution to the problem, I think, is primarily one is environmental, right? So we haven't always had this body shape. Our environment has changed, and our genome has not changed. And so we find ourselves as researchers in an odd situation to say, well, we don't have control over the environment, so we'll use the tools that we have available to come up with a remedy. It's kind of the idea that if all you have is a hammer, everything is a nail. So I'm just wondering from this group, I'll ask Susan and others, does one think that this is the most rational approach, most evidence-based approach to solving a problem like obesity is to give drugs for it, or lifestyle where we see the limited effectiveness and poor adherence versus, I mean, here right now we have a crazy Secretary of Health and Human Services that is talking about keeping people healthy. You talk about grants. Are there grants that should we be pushing policies to say just increase the cost of foods that are obesogenic? I mean, I'll stop there if people could comment, but please don't say, oh, it's not practical, it's a political issue, because everything is a political issue, right?
So David,
Go ahead.
I'm fully jumping because I'm so glad that you said this. Because I know we only have 1 minute left, but I think the 1 minute is well dedicated to, well served by dedicating it to this point. I agree with you. I do not think that the answer to the obesity epidemic that we have is medication. I agree with you that the reason why we are in this situation is multifaceted, and that's why I tried to show at the beginning, like pollution can cause it. And it's all these endocrine disruptors, and it's the ultra processed foods that we all are surrounded by all of the time. So there are things that we can change that would mean that we would not end up with kids with the excess weight that they have. And I think that we should definitely put effort and energy into addressing those things. So I believe in voting, so we get in people who can help us make the changes that we should make. I believe in advocacy to try to change those things because we do not, even if, and the last study I'll mention, if somebody has excess weight as a kid and then they ultimately lose weight, there are still changes in their metabolism that doesn't go away when you lose weight, right? So like when you have excess weight as a kid, it affects your chromosomes and they do not go back to completely what they were. They're more frayed, even when you're older and you lose weight. So do we want to subject kids to having excess weight and then have to go on medication to lose weight? And they still will not be as healthy as they would have been had they never had the excess weight. So no, I agree with you, David. We need to do all those other things. I was focusing on a particular area of research for today and what we're going to do with the lifestyle program, but your bigger picture is the perfect way to end. I hope you agree with me.